Welcome, everybody. Well, it looks like we have a lot of people here today. That's terrific. Well, welcome everybody and Happy New Year to all of you. I am thrilled to be kicking off this inaugural webinar series with two of the best people that we could have on this, people that I'm proud to call friend, colleague, and mentors from far. We have Dr. Jag Singh and Dr. Dave McManus, who need no introduction, and Dr. Jag Singh will be presenting first, followed by Dr. David McManus. Dr. Jag Singh is familiar to all of us, and for those of you who don't know him, he's a professor of medicine at Harvard Medical School. He is the former clinical director of cardiology and the Roman W. De Sanctis Endowed Chair of Cardiology at Mass General Hospital. He's also the founding director of the Resynchronization and Advanced Cardiac Therapeutics programs at Mass General Hospital. Dr. Singh completed his internal medicine, cardiology, and cardiac electrophysiology fellowship at Mass General Hospital. He completed the doctorate from Oxford University, a Master of Science in Clinical Investigation from MIT Harvard, and a research fellowship at the Framingham Heart Study. He has over 350 peer-reviewed publications and has given over 475 invited lectures at national and international conferences. He is the former deputy editor of the Journal of the American College of Cardiology Clinical EP and editor-in-chief of the Current Treatment Options in Cardiovascular Medicine. Dr. Singh is a national and global principal investigator on 7 ongoing multi-center clinical trials in device therapy, sensor strategies, and artificial intelligence for heart failure and atrial fibrillation. And he is a best-selling author, of Future of Care. If you haven't read it, please go get it. It's a phenomenal book kind of summarizing and laying out the plan for the future of care using all the technologies that we work on every day. Welcome, Jag.
Thank you, Hamid. It's a pleasure and a privilege to be here, and it's an honor to share the dais with Dave, Professor McManus. It's this is a large topic which I'm going to condense from 365 pages book into a 15-minute talk. But I'm really going to provide an overview, and hopefully we'll have time at the end to really deliberate on different aspects of how we can make some of this care possible. Before I start, these are my disclosures. I do consult for and do research with many of the major device companies, as well as those involved in sensor strategies and AI. With that behind me, I like to start with this saying that change is not merely necessary to life, it is life. And I think this is a saying that resonates with all of us out here, because I think all of us have seen a lot of change in life, whether it's socially, culturally, environmentally, or geopolitically, and we're seeing a lot of that actively. And so also, medicine is changing. We are going through this burgeoning metamorphosis of digital care that is going to change the shape in which we deliver and in which we receive care. And hopefully that's some of the things I'm going to talk about in the next few minutes. Very quickly, I'm going to try to break this up into some of the gaps in our healthcare system, touch on the role of sensors in a very balcony perspective view, talk about the data conundrum and the potential role of AI in healthcare, and if we have time, touch upon the future models of clinical care, which I think are going to evolve significantly over the ensuing years, if not, within the decade for sure. Let me start by saying that I think we all recognize that the U.S. healthcare system, that the one we all work in, is big, but it's also fat and sick. And I say that because nearly 1/5 of our GDP goes towards healthcare. And I think all of us recognize that that's equivalent to the economy of one of the developed nations in Europe. And despite that, there are millions of uninsured individuals. Our life expectancies are still fairly low, and the quality of care still leaves a lot wanting. And I think some of the concerns are that our care is inept, it's inefficient, and we've recognized during the pandemic that it's fairly inequitable. Beyond that, there are other concerns that it's very opaque. It's very opaque in how we practice medicine within different hospitals, regions, institutions. It's very opaque in the reimbursement that different organizations get. And that in itself has created this really opaqueness that prevents some of the change from occurring. And I think beyond that also, we recognize that we are beholden to this culture of margins. We talk out of both sides of our mouth and talk about value-based medicine, but I think we profess every living day of our lives chasing RVUs and chasing high-margin procedures. And I think we're a living contradiction out here, because 3 of our $4 in healthcare are spent in chronic diseases. And we'll talk about that in the next few minutes. But more importantly, the wellness of our institutions depends on the sickness of our patients. And I think that's something we need to flip that argument if we really want to change the way healthcare is perceived, and at the same time, how healthcare is delivered. I'm going to spend a few minutes talking about one of my patients who I think will help us kind of wrap the different aspects of care together. So I met Paul for the first time in 2003. I know we have a very diverse phenotype out here. Not everybody are electrophysiologists or cardiologists. So I'm going to try to build this up ground up. So Paul is somebody I met in 2003. He was 71 years old at that point in time. He had 3 chronic diseases. He had diabetes, he had hypertension, he had chronic kidney disease, and hyperlipidemia too. He was actually on hemodialysis for 7 years before I saw him. And he had significant end organ damage from all these chronic diseases that he had. When I saw him, he was class 3 to 4 NYHA. This was 2003. He had a wide QRS interval, as you can see at the bottom of his echocardiogram. So there was evidence of mechanical and electrical dyssynchrony. And at that point in time, he had been given a 1-year mortality rate of 90% and 1 year of 100% and 1 month of 90%. And I was told, and I was a fresh out of the cage electrophysiologist, and I was told to best leave this gentleman alone because the likelihood of him responding to any therapy with his comorbidities was very low. Nevertheless, I went ahead and as you can see from this, the electrophysiologist recognized that this is a very old left ventricular pacing lead. We were able to give him a CRTD at that point in time. And I'll continue to talk about him, but I think I really want to emphasize what went wrong out here was that his chronic diseases were allowed to progress to the extent that he developed end organ damage with his kidneys failing, his heart failing, and multiple other issues that we'll continue to talk about. And I'll come back to Paul. I think the main story in medicine out here is really not just diagnosing a disease, but really finding a tenable life with the disease for that patient. It's not about that 7-minute clinic visit narrative, but the narrative around the entire year that you don't see the patient, that is really important of how we actually manage these patients. And I think we try to bridge the gap between patient expectation and the working of the busy hospital. And I for sure fail on a daily basis because I'm not able to meet those expectations with all the other things that are pulling us in different directions. But I think now the time has come that we are in a position to change some of that. And we are now blessed with data. We are blessed with unlimited connectivity. We are blessed with massive processing power, which I think will transform the way we deliver care. And if I can leave you with one message, it's a very simple message, which I think everybody on this call already knows, that the future of care will be virtual, if not at least partially virtual, not fully virtual, will be sensor-rated in a big way, will be powered by artificial intelligence, and will need to have sustainable workflows that allow this care to be delivered on a daily basis. So let's break this down. I'm going to break this down into sensors, and I think I'm going to break sensors down to the senses. And there's a beautiful saying from Immanuel Kant who said that all knowledge begins with the senses. every sense we have, whether it's sight, it's ear, it's smell, it's taste, it's touch, all of these analog experiences that we have are equivalent to an electrical charge. Every organ in the body operates through a sequence of binary codes out here. And that allows us to now, for once, digitize the human body and potentially create digital dashboards, which are an automobile equivalence for check engine lights. And I'm not going to go into the details, but almost every organ system right now is currently being digitized as we speak with either wearables or implantable sensors that will provide us the opportunity to monitor, to forecast, and then proactively intervene in disease and prevent disease in the future. I'm going to take a step back and really tell you what we've been doing for many years. And these are device-based sensors. And we as electrophysiologists, I know not everybody's an electrophysiologist out here, but these implantable devices, that is this pacemaker device or a CRT device or an ICD device that is connected to the heart with pacing leads, as you can see out here, these devices have simple sensors that can measure heart rate, accelerometers that can measure physical activity, have impedance measures that can measure the fluid levels in the lung, can measure heart sounds that can be a surrogate for cardiac contractility, and measure respiratory rate and respiratory tidal volume, all of which can actually tell you how well or bad a patient is doing. And beyond that also, obviously, we have umpteen sophisticated sensors that I won't get into, but they can provide you specific information regarding left atrial pressure or pulmonary artery pressure and things to that effect. Beyond that, beyond these implanted devices with these multiple sensors, we have standalone sensors, which can be implantable loop recorders. They can be the VLAP sensors, which are on the interatrial septum. They can be in the pulmonary artery. They can be in the left atrial pressure sensors. This is a part of the study that we did, which was subsequently stopped because of safety reasons. But just to give you an idea that you can have sensors in every aspect of care out here that can provide you information regarding the cardiovascular state of affairs. Now, these implantable sensors can be used to risk stratify patients, can be used to predict disease as well as prevent disease. And some of the work we did with sensors started way back in 2010, where we used simple measures from within these devices to predict which patients were going to do poorly, which patients would go on to develop heart failure, use sensor device strategies within the devices to help reprogram the devices from a sensor within the right atrial lead that could measure cardiac contractility. And then obviously using all these sensor strategies, help predict which patients would develop heart failure 30 days before they actually develop heart failure, using an integrated sensor strategy with heart sounds, thoracic impedance, activity, respiration, and arrhythmia. So all of these, when put together, provide a better strategy of actually predicting which patients are going to have heart failure well before they actually have it. Now, I know we talk about implantable sensors, but your question is going to be, not everybody has an implantable device. How do we monitor those patients? There are a slew of wearable devices, and I'm not going to belabor this because of the constraints of time. There are tattoo devices, there are wearables, there are pressure sensor devices. There are almost, I think, 600 to 700 wearables right now that help assess many of these different measures that we talked about. And by the end of this conversation, probably there'll be another 10 out there in the market. And then you have ambient sensors that can actually measure your weight, measure your ECG, measure your microbiome. So there's a lot happening within this field. And I think all of us know about continuous glucose monitoring, which has become such an important part of how we actually manage these patients. I'm going to take a step back and talk a little bit about Paul again. And so Paul's heart function now from 17%, I forgot to mention that ejection fraction, as you saw from his echocardiogram, was 17%. His NYHA class was 3 to 4. His EF now started improving, and his EF became 45%. He was still very brittle, still had multiple admissions in 2005, so he'd survived now for 3 years, and was noted to have atrial fibrillation too. But just to, again, remind you, at that point in time, there were no sensor strategies. There was very siloed care, and really trying to manage brittle patients like this was a bit of a challenge. I'm going to spend 2 minutes talking about heart failure because it becomes important to tie this whole case together. Now, heart failure, we know, is a common problem. It is one of the commonest causes of readmissions. About $70 billion will be spent on an annual basis by 2030. And every readmission we can see out here never comes back to baseline, and patients continue to do poorly until they have a progressive decline. And it is here that device-based sensors help us predict and prevent disease. Now, this is a slide I actually made in 2010, thinking of sensor strategies that will allow us to predict which patients from chronic heart failure will develop heart failure hospitalization. And now, in 2023, we are in a better position because now we have not only baseline measures from sensors that can measure the sympathovagal balance, we have sensors that can actually measure comorbid conditions like diabetes, hypertension, COPD, and AFib. We have triggers. We have sensors that can measure triggers such as electrolytes and arrhythmias that actually precipitate and trigger heart failure hospitalization. We already talked about the sophisticated sensors. We have additional device-based sensors. So you can only imagine that using this information collectively in an individual patient will provide us a much better sensitivity and specificity in determining which patients develop heart failure hospitalization. Because now we have all these sensors available. It is the question now of bringing us all together to integrate these information to actually provide better care to these patients. The question comes up out here is, this is a lot of data. How are we going to manage all this data? And I think it's important to recognize that there is the health data platform that is evolving as we speak. We all recognize the EHR or the EMR, which has our demographics, medications, billing codes, and all the other good stuff that we know about. But it's the evolving sources of data, which include the variables, the biosensors, the social, cultural, environmental data, which are responsible for 80% of disease, and obviously the omics, whether it's the genomics, the microbiomes, the proteomes, all those are evolving sources of dark data that I think will provide us better information as to how we manage the individual patient. There's a lovely saying by Daniel Morans who says, you can have data without information, but you cannot have information without data. So there's a lot of data out here, and we will need AI here to compute all this data. And this can be used in different forms, whether it's conventional AI, multimodal AI, and generative AI, which is beyond the scope of this particular talk, but happy to discuss about that later on. Now, Paul had heart failure, but he had atrial fibrillation, as we talked about, and had renal failure. There are many strategies now for helping better risk predict atrial fibrillation, better risk stratify atrial fibrillation. Off the 12 lead, off the patch monitors, you can now predict which patients go on to develop atrial fibrillation within 14 days, 31 days, or 5 years based on the slew of publications. And there are also scalable strategies now that you can actually measure and predict AFib off watches where to measure the QT interval using cloud-based algorithms that, again, I will refrain from getting into the details of. Paul had hypertension. I think we all know now that there are machine learning strategies that can better phenomap patients as to which patients require intensive blood pressure control versus those that do not require intensive blood pressure control. And this is some of the data from the Accord BP study and the SPRINT study. And there are non-tough strategies now that are being validated, as you can see out here, that will allow us eventually in the near future to better measure blood pressure on a beat-to-beat basis or on a half-hourly basis or an hourly basis, however we want to measure it. There are a slew of different variables that are being assessed at this point in time as we speak, and some of them actually already finding their way into clinical practice. So what happened to Paul? So Paul actually went on to do pretty well. His ejection fraction normalized from 17% to 70%. He became eligible for a renal transplant, and his anonymous neighbor, 19-year-old anonymous neighbor, donated her kidney to Paul. So here Paul was 76 years old now with no heart failure and no renal failure. He went on to becoming a dancing instructor at the senior center, where he actually met his wife, married his wife, and went down to Florida, where he started an antique business. Paul is 91 years old today and had been given just 1 month of survival time about 20 years ago. And I think the lessons we learn are that chronic diseases were allowed to progress to renal failure and heart failure. And it was all preventable because over the last 20 years, Paul has not had renal failure or heart failure and has been monitored and managed in a multidisciplinary clinic with all the data from his device also. And I think in the past, siloed care, which was episodic and transactional, led to Paul losing many years of his life and his youth. And you can only imagine the impact it had on his life, as well as the healthcare system that incurred huge expenses. I'm going to very quickly talk about some of the future models care, but I think it's really important that we have to recognize that the only way of ensuring sustainability in our healthcare system and really answering the demand for value is really the construct of digital pathways. And I think we do have to remember that being digital is very different from being digitized. Just having EMRs doesn't make us digital. Being digital is a culture change. It's a change in the value proposition. It's a change in how we start thinking of how care has to evolve from becoming transactional, that is on a 6-monthly, yearly, or 2-yearly basis, to something that is more continuous, something that is supported by AI-driven logic that allows the evolution of algorithms. And some of this is exception-based care that we in electrophysiology have already been doing. We used to follow these patients with implantable devices on a monthly basis and a 3-monthly basis, and now we see them once a year because all their information now is remotely monitored. So this is exception-based care. We pull them in only if their device looks out of whack. The same kind of evolution of care will eventually happen when in these sensor-based strategies that we're talking about. Very quickly, I think the future of care is basically revolves around remote monitoring. Remote monitoring is the only way that we can put our arms around the life cycle of disease, and this will obviously need a synergistic convergence of generative AI along with conventional AI, with clinicians understanding that these are needed if we need to really improve chronic care, reduce readmissions, facilitate self-management strategies, and at the same time, try to make health equity as global as possible. There are many high priority areas that are already finding their way into remote monitoring, not in the conventional way of sensor-aided remote monitoring strategies, but really virtual-based approaches to perioperative care, for hospital at home care, and specialty high burden care. This is an important point that I'd like to make, especially in our academic medical centers as they evolve. When I look at care, I try to kind of subcategorize it into upstream care, which is specialty services and complicated care. There's this whole midstream band, which is chronic disease management. And there's this mainstream care, which is wellness. I don't think our academic medical centers, or let's put it, my heart failure team out here within Mass General has about 11 heart failure physicians. They've followed 7,000 patients. I don't think they have the ability to monitor and manage these patients on an individual basis, on a daily basis, to prevent heart failure readmission. I think the status quo is untenable. We have to innovate and experiment. We will be needing the use of third-party vendors to actually help create some of these disease management models that will be an essential part of the future model of care. And this is going to erode into the finances of the academic medical centers. And I think we have to recognize that some of the future models of care will involve shared saving strategies, will need disease management models with the help of third-party vendors. We do need self-management approaches. And obviously, there are many strategies that are currently being employed for enhancing the Uberization of healthcare, whether it's meeting in the metaverse or using asset-light approaches. So there's a lot going on. Unfortunately, I can't cover all of this, but I would like to close by saying that the secret of the care of the patient lies in caring for the patient. It's a beautiful saying from Francis Peabody. And I think care must always be personal, technology forever tamed, and we should continually strive to preserve the human touch in this burgeoning digital metamorphosis. Thank you very much for your kind attention.
Thank you so much. That was really a tour de force of where we were and where we're going, and how we're going to be managing patients going forward. Our second speaker is Dr. David McManus, who is the Richard M. Haydick Professor of Medicine and Chair of Medicine at UMass Chan Medical School. He finished his biology degree from Brown University and went on to do his medical school at Massachusetts Chan Medical School, and continued his internal medicine residency at University of San Francisco, and cardiology and electrophysiology at UMass Chan Medical School at Worcester. He is executive director of the Massachusetts Medical Device Development Group and is the primary investigator on a $123 million NIH grant to develop and test the points of care technologies, the so-called RADx group. He's an active investigator on multiple R01s and a U54 grant. He has published over 350 peer-reviewed publications, and he's the founder of the Center for Digital Health Solutions at UMass Memorial Health. Because he hasn't achieved enough, he's currently getting an MBA at MIT, and we're very excited to hear him talk about how he's actually using all his knowledge on a system level and incorporating into care. Thank you, David.
Thanks, Hamid, for inviting me. Great to share, as Dr. Singh said, share the podium with him. You'll hear a lot of hopefully complimentary messages. He can be the Charlie Parker to my Miles Davis, hopefully, and we can make some good music together about this topic. It's also great to reconnect with the Michigan Frankel Institute. I met many of you a few years back. I think, is it pre-COVID, Hamid, that I was, forget exactly when it was. It's been a blur, but happy 24 to a lot of new friends in Michigan, and really appreciate the opportunity to speak to what is a great innovation group that, quite frankly, we've modeled a lot of our thinking and action after. So you might see some of yourselves in my talk. So I want to start off with a quote. I loved many of Dr. Singh's. I thought they really framed his conversation with you nicely. I'll start off with one too. This one from Isaac Asimov, who said, "It's only afterward that a new idea seems reasonable. To begin with, it usually seems unreasonable." I would ask that you, maybe suspend disbelief for a bit for this talk. I would like at the end to have a conversation with you, and please feel free to email me afterwards if you want to get involved in any of the initiatives that I mentioned. I would say, as a case study, interestingly, you may not know this, but Asimov, who was a real futurist and thinker about things like artificial intelligence and automation, himself actually applied to medical school and was rejected multiple times. So he ultimately found his calling, got a PhD in chemistry, and found his calling as a science fiction writer. And I would argue that much of what was fiction has become science from his work that captivated me as a child. He probably was more involved in my development than any med school professor. Also, by the way, developed a complication from a bypass. He got HIV from a blood transfusion during his bypass. So speaking of medical errors and opportunity to improve our health system. Some disclosures. What are we looking to accomplish today? Three points, three things. One, understand we are at a tipping point. I'll briefly mention this because I think Dr. Singh did a great job emphasizing the challenge to American healthcare that exists. Two, I'd like to discuss some competing visions for what exactly digital health is. I think you saw a few different lenses. Looking at an idea through multiple lenses is often helpful at sort of trying to grasp it fully. And what is digital health doing to healthcare in a sort of a planned and strategic way? And as is often the case, like when the Apple Watch was released into the wild without really us having participated in its development as healthcare professionals in thinking about it system-wide. Lots of patients throwing ECGs at us, for example, but really, was there data, for example, that it improved outcomes of patients with AFib? No, right? So that's an example of a disruptive technology release that reshapes healthcare, but potentially in unplanned ways. And that's as common or more common than planned transformations. And then finally, I was asked by Hamid to talk about a few examples of how we're using I have a role as a chair in a department, which is largely a role of influence. So I can't tell people what to do, but I can ask nicely. And so we are trying to influence how healthcare is delivered through a program that was mentioned earlier, the Center for Digital Health Solutions. Quickly, really nicely summarized by Dr. Singh, we're spending a lot on healthcare and not getting enough. We're not getting enough as it pertains to quality. We're not getting enough as it pertains to a quantity of life. This is something that, if you've not seen, there's a great editorial in the New York Times about this topic. Dr. Jha, the dean of the School of Public Health at Brown, had a great quote about the squishiness of longevity being a barrier to politicians like President Biden really focusing on the decline in the American life expectancy as a major focus of his hopefully second administration. I know I'm talking to folks that might be politically not cool to say, but anyway, long story short, it's a topic. It's a topic that's really not focused on at the highest levels of our government, but it's a shame. And it's something that we in healthcare really should, if we're not going to solve this, we've got big trouble in terms of our economy, but also in terms of our standing in the view of the American people. So what is digital health? The FDA defines it as sort of a set of tools: IT, wearables, telehealth, telemedicine, personalized medicine. Others define digital health as a discipline. So something that you're trained as a provider, as an engineer, to learn how to use to care for people. HIMSS defines digital health as something that connects and empowers now populations, teams, systems of care, care environments. And MESCO, who I really like this definition because it's aspirational, is really a cultural transformation. I think that's something Dr. Singh really captured nicely, the idea that there really is more than just technology at play, that multiple data streams being accessed by both patients and caregivers really changes the patient-physician relationship, shared decision-making, and democratizes care. Well, however you define it, rates of utilization are skyrocketing among all groups: older people, folks who have had more trouble accessing healthcare in the past, marginalized and minoritized populations, all are seeing upticks. In fact, I would argue actually marginalized groups are actually adopting these more, in part because they have had so many barriers to accessing healthcare. I love this. I saw this presented at a talk and I had to use it. This graph of rate of change over time. The rate of change in technology, particularly around automation and artificial intelligence, has vastly outstripped the rates of change in our political enterprise, our frameworks for evaluating the ethics of tools, business. Have we really changed healthcare and reimbursement models to adapt to use of AI? I think Dr. Singh has highlighted nicely. We do very much still live in this fee-for-service world, despite having the technology that could take us into a very different place. And we don't quite know where this will end. It will destroy, but it will also create jobs. It will benefit and impair workers. So in the short term, I believe that it will largely enter into healthcare at the back of the restaurant. Things like HR, billing, compliance, helping make it a little bit easier to do notes, these sorts of things. But over time, it will enter into the front of healthcare and affect the job of a medical assistant, our experience as physicians, and it already is happening. But that, I believe, is the entry point for AI in healthcare, as opposed to replacing doctors to make diagnoses, which I think is a bugaboo. Okay, I just said bugaboo, but then I'm going to try to shock you. I do believe that you are here. That's Burning Platform is in fact a reference to some folks who had the unfortunate decision of, what do I do here? Do I jump in the water or die? I think we really suffer the potential fate of Blockbuster to Amazon Health's Netflix in the streaming wars. You see rates of community hospitals closing, going up. You see the cover of Newsweek showing Jeff Bezos in a white coat. And I don't think it's hyperbole to say that change is happening. It's happening rapidly. At least in Massachusetts, every single health system lost extraordinary amounts of money last year and the year prior. They're really struggling despite having, I think, a preeminent status in American healthcare. But struggling is different than closing, which is what's happening in rural America to many safety net hospitals, because Amazon Health is getting the money that comes from Medicare and other payers but it's not open at midnight if you break your leg and need someone to see you in the ER in a rural hospital. That's a problem. So one of the things I want to emphasize is that most people want telemedicine for their lower acuity conditions. This, granted, there's selection bias in any sort of survey, but I think it's fair to say that 2022 was a tipping point, according to Stanford's and Rock Health's excellent survey of patients, whether it be for prescription refills or minor illnesses. Patients would prefer ECG checks, Tecasin checks, these sorts of things that are common in the EP world. I think people do not want to wait in the waiting room. They want to do a lot of this from home. It's not a stretch, right? I think we all have experienced that in our practice. And I think the other point I want to make is this is what's advertised now. If you go onto your Amazon, as I do to order my electronics or my books, like Future Care, hassle-free primary care is here. And this is an advertisement of One Medical, which is the second large practice that was purchased by Amazon over a period of years. This is not a flight of fancy. They are here to stay. And here is their comparison of their services versus the typical practice. And I would have to admit, our primary care practices at UMass do suffer the challenges offering 24/7 care and on-time starts, et cetera. And so this is what is being advertised to patients. I put this slide up because I think we do have certain advantages in healthcare in that I believe that most of my patients don't like Jeff Bezos. And they would like us to win. We have established standing with them, respect. I think nursing is one of the top most respected professions in the United States. And physicians, although we're lower than nurses, are still very much up there as a trusted partner for patients. And that, I think, for example, at Michigan, your community really loves and respects you. They show this through philanthropy, sure, but they also show this by showing up in your clinics and showing you a tremendous amount of respect as you care for them. That is your greatest asset. That is the thing you have that Amazon does not have. That can be lost. But I put this picture of a nurse at a field hospital that we stood up during COVID. And I think these sorts of things that we do for our community really matter and are things that Amazon will not do. Okay, one of the things that was not mentioned, but we should, this is a quote from my favorite and I believe the most accurate medical drama on television, Scrubs, which of course pokes fun at surgeons, which I love, where Turk, who comes around from being a surgical resident to a medicine one, says to Cole, the boneheaded pre-orthopod, you don't want to be a surgeon, Cole. It's boring and it sucks. It's the complete opposite of a water slide. Well, that's the experience, unfortunately, of a lot of people in healthcare right now. We've seen departures of about half of nurses in our health system, retirements or cutbacks. We've seen a lot of use of locums. We've seen our challenging ability to staff clinics with medical assistants who can make more money as a Starbucks barista and not be berated as frequently in the job. And so we're really struggling, and that's put an added burden on those that remain. And so most people, as shown in this survey from a morning consult survey, who are in healthcare, say that they are over capacity in their ERs. They have to work more hours to try to make up for departures. And the workload is just overwhelming. And that's something that I think we should consider when we think about digital health, because it's held up as a mechanism to address some of these issues, either directly or indirectly. One thing I'd really like to highlight is this concept of the learning health system that's put up on almost every talk I go to. AHRQ has this great, virtuous cycle. At least at UMass, there are so many barriers to really using our health data in the way that Dr. Singh mentioned. We have not structured our health data to be truly useful, to generate knowledge. Sure, if you want to have an 87-page discharge summary full of nursing notes that have no relevance to the patient's long-term care or plan, we got that. But do we have something that pops up at the moment when I see a patient to highlight those conditions or labs that were a little bit different, out of sync, potentially an AI co-pilot that could really help me in clinic do a better job? No, I do not. I would like to, but unfortunately, to systematically integrate, we need to do what Dr. Singh mentioned, aligned incentives, RVUs versus quality outcomes, length of stay. How do you get, and you'll see that play out in a moment. Oh, and yeah, best practice advisories. Do those not drive you nuts? I mean, we have this sort of advisory cytosis where there's no consideration to the ultimate end, each person, tobacco cessation and this cessation and that. You know, by the end of it, it's just 20 minutes of clicking through best practice advisories when all you want to do is prescribe Viagra for your patient. This is not smart care. Layering on more stuff is not the answer. And I believe that the current construct is not sophisticated enough to design the solutions that we need. I want to tell you a story of a team of people that came together to try to take a tool that I saw displayed at Hartford Hospital, which is an integrated a system in Connecticut, where they had applied an AI-assisted clinical decision support tool very thoughtfully on hospital medicine services. We really do struggle at UMass from being underbedded in relation to the population growth in our area. And as a consequence, our ER is full, and we really need to utilize every second of every day of an inpatient medicine bed very thoughtfully. And we were looking to reduce an increase in length of stay we saw during COVID when a lot of skilled nursing facilities closed and long-term care facilities closed in our area for a lot of the same reasons that I mentioned us struggling in healthcare, staffing. And so we brought together a team of IT professionals, engineers, a group from MIT, as well as others who had built AI models with nursing, physicians, as well as residents to try to build a tool and integrate it. And that's the key point. Tools alone, sensors alone don't work. It's the people who use those sensors in new and thoughtful ways that really make a difference. So this is a photo of our group coming together to try to workshop this new tool. You see represented a number of people. We had a rock star who wrote a book on analytics and use of AI, Dr. Bert Simis. He's a very you should have him come out to Michigan, Hamid, by the way. He's great speaker and very thoughtful person. And so we redesigned our health data in a new way to enable AI to be useful and accessible to clinicians, which it previously was not. So our med school and our med center are separated by a firewall. And so we pull Epic data into a research database that was largely used for outcomes research, but was not a living, breathing thing that could be used by clinicians. So if you, like me, don't like circuit diagrams, I had a colleague label this for me because I'm not as smart as him. So we pulled our Epic data into this spot. Predictor variables were pulled out. Models were trained. There was a safe sort of Switzerland zone where the output could be processed by AI without affecting the larger data set. There was a lot of thought given to security, model output through a web accessible portal, and the clinical teams could use these during what we call our multidisciplinary rounds, where case managers, for example, could prioritize who got physical therapy in the morning on the basis of the AI tool's prediction of likelihood of discharge on that particular day. This is the tool, and these are some of the probabilities that an XGBoost model. These are greenies because we like greenies. Greenies are people who have improved in terms of their likelihood of discharge. Again, this is a non-hypothesis-driven AI-trained tool on our data. It includes social factors, zip code, other data, subject to bias, which is something I'm going to talk about in a moment, and a number of other limitations. But it is an extremely useful tool when used thoughtfully by clinicians. Where are we going next? These are some of the places that we plan to take our predictive analytics team's focus, whether it be ICU triage, whether it be predicting where a patient needs to land, SNF, home, hospital at home, and some of these other clinical purposes. I want to tell you quickly about our hospital at home. Dr. Singh mentioned it. We are very proud of our hospital at home program. It is a virtual care ward. We have almost 20 patients at any one time in it. We just, I think, had our 1,700th patients. I think we're the 6th biggest in the country, and it recently won the #1 program in the year from an association that evaluates this. It required a lot of build of sensors in home into Epic such that virtual hospitalists would be alerted real time and paramedics could be sent to the home and able to care for patients with acute conditions, complex patients, heart failure patients, et cetera. And in fact, our outcomes have been excellent. I would strongly advise you to consider growing your cardiovascular hospital at home presence. And that's a take-home point I wanted to emphasize. This is where we're going. We're expanding. This was from a website from Best Buy who advertised using UMass because they bought the company we worked with. We have grown since these data that were online to about 20. Our length of stay remains below the brick and mortar, and you can see some of the data in the bottom right. We do really want to extend flexibilities to avoid patients having to come to the emergency department. And we just got a grant from the state to work on a skilled nursing at home program and actually do a randomized trial to see whether or not that is superior to conventional skilled nursing in a fashion that is similar to what we've seen with hospital at home. Real quickly, another place where these tools and this concept is applicable to cardiovascular is in the rehabilitation context. We had to close our brick and mortar post-MI cardiovascular rehab center. Very few exist in central Massachusetts within driving distance of our patients. And this is a great need. There's a lot of development in this area. Another opportunity, I think, for cardiovascular to invest, bring its expertise and work with industry in a very thoughtful way to disrupt and improve outcomes for our patients. One other point is training. So we recently received a notice of award of an NIH training grant from physicians and PhDs who wish to do a year doing research in digital health. We also recently started an informatics fellowship. These are some of the faces of physicians who have decided to train further in a multidisciplinary curriculum focused on informatics as well as AI mobile health. And I like to use this quote that AI is not replacing us, but you better believe that these physicians who have AI expertise are going to be more desirable to employers than physicians without AI expertise. So develop your own program. Next, we're giving out stimulus grants. I love this concept. It allows us to give out 40 to 50K to a physician to buy out what is in essence with fringe for most of the, say, a rheumatologist or endocrinologist, a clinic session, to pair them with an engineer and to give them a year, not as a sinecure, but as a focused project. They apply, they are on the hook for presenting, but they're given the tools and time, because that's the critical thing, to develop digital health solutions. And we've seen digital diagnostics, targeted therapeutics, and care efficiency as the main targets. Lastly, health AI assurance. This is a big deal. I'd like to emphasize that we all need to participate together in evaluation and reevaluation of many of the promising AI tools that are being sold to us by industry, and that we are ourselves developing. And there is a consortium called the Coalition for Health AI, which has emerged and will be, I think, the major partner for FDA in deciding what is appropriate for us to use and what is not. So the answer to my clickbait talk title of can digital health save healthcare is no. It cannot, obviously. I believe we can. I hope it is us that does it and not Dr. Bezos. But I do think that we can't do this without embracing change. We do need to think differently, as Dr. Asimov asked us to. We need to think much more, as Dr. Singh mentioned, about care in the home, care provided outside our comfort zone at potentially times that are more convenient for our patients, and adapt to the needs of our consumers. New people, upskilling of nurses, with AI at the point of care ultrasound. Do you need an echocardiographer anymore in that context? Or would his or her time be better spent elsewhere than evaluating a normal echo, potentially in the home of a patient hospitalized, like Dr. Singh described? I think it was Paul, was it Paul, Jag, that was your patient? But so Paul might, if he were in the home, have had one of these devices be able to monitor his response to CRT and provide a lot of real-time feedback to him and his rehab nurse. And finally, I would like to just thank you for your attention, to say, close with this quote from Asimov, that predicting the future is a hopeless, thankless task. So I hope you won't subject me to too much ridicule and or scorn. Thank you for your time.
Thank you so much. That was fantastic and really wonderful to see that a lot of the things that Jack has been talking about, you've actually implementing in real world and changing lives of patients and improving care overall for your institution. So really wonderful. So with that, I think we want to open it up for some questions and discussions. Is there any questions from the
I
group?
can just start
Oh,
the conversation. Hey, Dave, that was an amazing talk. And, you know, I think for any organization to really change requires visionary leadership, which clearly you're implementing. It requires a top-down approach, because you can do a lot in the periphery, but if it doesn't change the culture of the organization, you're combating against headwinds throughout your life to really kind of orchestrate some of that change. My question to you is, it's something I've been thinking about is something about disappearing disciplines, and kind of redefining, repurposing and redeploying clinicians of the future. One of the things that I'm a little bit afraid of is that we are overhiring cardiologists right now, for example. We need warm bodies to see patients. But I think in the next 5 to 6 years, for sure, many of those chronic disease states can be managed by algorithms with advanced care practitioners. And how do you kind of envisage that? I mean, what is your ploy to think of how the next 5, 10 years are going to play, and how do you span that time?
Great question. I would say, I think you're correct that we have to be really careful. And you could see it happening over the last 25 or so years with fixed professional fee reimbursement, but facility fee, and now lump sum payments, kind of DRG-based payment models coming to health systems, where and restrictions on advanced practitioners being lifted around independent care, and around equal reimbursement. We saw this play out very, very acutely for us in our critical care setting, where split billing, which the physician used to be able to go by and bill for their time. Now, if a nurse practitioner spent 2 or 3 hours with the patient, and the doc 15 minutes, the nurse practitioner's note and bill was the one that was paid. That sort of these skirmish battles that are happening and really not reshaping how we're thinking strategically are going to spread. And I think you're spot on that we are in a period where I do think some very careful thought needs to be placed into where you are hiring. And if a cardiologist is an expensive professional, on the one hand, you don't want to burn out the people you have in today's world, but you also need to realize that you are likely going to have to go to someone else to ask for them to pay for that person's salary very soon, because the professional billing and some of the facility fees and some of the other technical fees are capped or coming down, and their salaries continue to go up. So at some point, and at least that's hit us, I don't want to speak too much out of school, that means that you have to really, from a financial and economic perspective, the balance is now shifted towards thinking about team-based care, and trying your best to think about where you can deploy your limited human resources to have the maximal clinical benefit, population benefit, but also you do have to think about how do you pay for their time. And I think that that's really, ultimately, you don't have to be a strategist to feel that. And a lot of folks that don't want to think about digital now have to. So we're seeing some different decision-making happening here. I would ask you, are you also seeing that?
Yeah, no, absolutely. I think, I don't think, that's where people are not paying enough attention still. They are looking quarter to quarter. They're looking to make sure they don't stumble and trip over their own legs. So they're looking down rather than looking forward and saying, you know what, the only way we can make this sustainable, as you've so elegantly put, is to really adopt the digital strategies and find alternative pathways that can be paid for in a much more, meaningful way. Whether it's transitioning from, revenue value, RVUs, to digital value units, or create some sort of measure for digital touch, because I think the digital or whether that comes into some sort of outcome shared saving strategy where you say, RVUs, digital touches, all combined into one, because that's probably how it's going to have to be. And then you kind of share the spoils.
Exactly. I think you just laid out a potential framework for doing it. That DigiGrant concept, which was pay for time, came actually from a UCSF professor, Rushikoff, who was a diabetologist, who Bob Wachter, when he came out to give a talk, if you haven't read his book, it's a really interesting one too. He had the foresight to pay this endocrinologist to virtually round. And that time was paid from kind of a departmental resource, not in a fee-for-service framework. But the downstream benefit was he was able to pop in proactively and improve the care of diabetes for inpatients on the teaching services. And so that type of model of care provision and pay it doesn't exist at the federal level in a way that's broad or deep enough to really be felt today, but it's there. And I think we're experimenting with it, and we will see in our practice lifetimes. I think within the next 5 years, we'll see that probably. I mean, look, in the last 20 years in Worcester, we went from 75% private practice to almost none. That's and I'm not that old. So I think that type of seismic shift is going to happen in this space too.
Yeah. No, cardiology division at Mass General 7 years ago was a private practice. And now it's a completely team-based operation. Sorry, Hamid, you were going to say something. We're hogging the field out here.
No, this is wonderful. And we've been thinking a lot about payment and payment innovation, so I'm glad that you guys talked about it. And one other area that we are seeing a lot of resistance with our technologies when it comes to implementation is clinician adoption, and the fear of like, oh, I have another number to look at on an EHR, or anybody who's reading regular ECGs when they're asked to only read difficult ECGs, or radiology, and there's no normal sinus ECGs. I'm just going to be reading difficult ECGs all day long, or radiologists only reading difficult X-rays. So how are you thinking about implementing these without overburdening the clinicians, or leading to burnout potentially?
Yeah, I'm happy to kind of go first. But Dave will have the more practical solutions, since I think he's dealing with these on a daily basis. I think this is where the culture aspect comes into play. I think the leadership within an organization and the division has to really kind of spell out, where we are and where we think we are going to be. And these are some necessary changes that we will have to make to be there. Right now, many of our organizations are overtaken with this whole concept of systemness, which is fine. I think it's a great platform to take it to the next level of networkness, or the connectivity that we were talking about, or this individual changes that are going to have to be a part of that expanding digital culture. I think some of these initiatives need to be federally mediated, that is from the top, but much of them have to be done at the division level and even at the section level, which is where I think leadership sometimes kind of breaks, where the top leader may have the vision, but it's not communicated with the same vigor to every participant peripherally. So I think that's one strategy. Then obviously, I think initially creating the right incentives around it are important, because to bring about culture change, I think you need to initially, unfortunately, always incentivize things. once people start believing in something, then you don't need to incentivize things as much because they can see the outcomes and the results of whatever change you're trying to drive. And these are initiatives I think oftentimes need to percolate from within the sections itself and then be promoted. But Dave, I'd love to hear your thoughts on this.
Yeah, no, I both am conscious of time and also the fact that you've answered it really nicely. I would add, Hamid, you actually bring up, I think, a major challenge, which is in the short term, there are disincentives to actually adopt innovations. And one of the major ones is fitting it in and on top of a practice structure that is perverse. So my perspective on it is, when Dr. Kim Eagle was training, the people who trained him saw only the hard cases. And Dr. Eagle in the 70s, he was not reading lots of normal EKGs when he was training, right? So this concept that physicians are rats on a treadmill just churning 3,000 ECG reads a day, that's the perversion. So just, I want to step back and say, like, it is true that when you're on the treadmill, it's hard to say, like, I'm turning the treadmill up 10%, right? So maybe you have to think about, from the perspective of the cardiologist trying to keep up, you have to demonstrate recognition for adopting that, that innovation. For example, we paid the hospitalists on the units where we wanted them to attend multidisciplinary round and use the AI tool for their time. What a novel concept. Because otherwise, guess what? They were running around trying to do their jobs.
Yeah, I think incentives to create collaboration and synergies is so important. I think there are so many interventional aspects of medicine that you have team-based approaches, and trying to break them into incentivizing people more equitably. And we can get onto this for hours, but I think you're absolutely right, Dave. Thank you.
We definitely can talk about this topic forever. But I wanted to thank both of you and everybody who joined for a wonderful inaugural webinar for our innovation group. Thank you so much for your time, and we will make this recording available to everyone, and hope to see you again soon on January 17th, where we'll continue our discussion. Thank you so much. Thank you for spending the morning with us.
Thank you, and
great to
happy
see
New Year
everybody.
to all. Take care.
Happy New Year. Thank you. Bye-bye.
Happy
Thank
New
you,
Year.
everyone.
You want to stay, Ashley?